specifically, we're looking at harnessing. Oh, let me change that back. That recording threw us off. Can you see back onto the slides now?
Yes, sorry.
Amazing, no worries at all. So yeah, it was originally a project looking at forested ecosystems specifically, but now it's much broader. So it's developed into multiple projects and also now PhD projects and master's projects, which I'll be advertising later in the year, which is very exciting. So with limited time, I thought the best use was to give you an overview. So an overview of the rationale, the conceptual framework, research, our preliminary findings, and then what our next steps look like. Now, I have to say this is a project that I have built by myself over years and have slowly started to incorporate a number of other anthropologists, epidemiologists, etc., in this One Health aligned project. So it probably comes as little surprise that there is a need to develop new, innovative and sustainable surveillance systems for tracking emerging infectious diseases globally. Now, in light of recent outbreaks such as Ebola, Marburg, Rift Valley fever and Anthrax, it's kind of really shown us that there is a need to better understand not only the biological, but the social dynamics that influence pathogen spillover. Now, one of the anthropogenic factors that influence spillover, that I spent a large part of my research career looking at, and I'm continuing to, is wild meat consumption, collection, and scavenging. Now, I've been working predominantly in Uganda and DRC, but also much further afield now into Guinea, Sierra Leone, etc. But although we don't quite know the scale of wild meat consumption globally, it is estimated that gram for gram, it's pretty similar to that of coffee. So as you can imagine, that is huge. Now, with the collection and consumption of wild meat, as you can imagine, there are a number of risks involved in encroaching into wild spaces, not only from being attacked from animals, but handling meat, coming into close contact, etc. So this is the one social dynamic that I spent a large part of my time looking at, and really provides the foundation for this project. So to give you a brief overview, and I will go into more detail with these in a second, but this is what Preventing Patient Zero looks like. So all of the projects that exist underneath this tie into this very simple theory of change. So our concept is we want to think of ways to report emerging infectious diseases, both epizootic and zoonotic, earlier. Those of you who are not aware, epizootics are diseases of epidemic proportion, but only occurring in animal populations. And being a One Health aligned project, we want to ensure that we improve conservation efforts through our public health interventions, and also work to mitigate the effects of epizootics as well as zoonotics. So most of you should be aware, but zoonotics being those diseases that can be transmitted from animals to humans, and then also from humans back to animals as well, and it can go in an endless loop. But think of novel ways to really identify these diseases before a patient presents at a clinic, at a hospital, etc. And I will talk you through that in a second. And the thing that really underpins this is harnessing community knowledge to track the emergence of these diseases. Now, this is paying great attention to empirical, local, indigenous, and tacit forms of knowledge, often hosted by poachers and other community members. So it's really tapping into the expertise of those individuals who are reliant on rainforests, for example, and tapping into their knowledge of these species and their habitats. And I will again talk a little bit more about that in a second. So the products or the inputs, we've already piloted this, but it's a co-developed community-centered surveillance system. So this is through working through a number of community engagement initiatives with active and reformed poachers, where we've looked to collect data on how this would best serve the community, but was also tangible and also provided alternative livelihood support for active and reformed poachers. We pair that with very large scale qualitative data collection, which again I'll explain in a second, a extensive community engagement strategy, and what will be coming later is a public engagement kind of strategy, which engages with rationales for wild meat consumption, etc., and the behaviors around that. I won't go into too much detail about this, but ultimately the outcomes are the early detection, to develop sustainable community-centered and community-owned surveillance systems, and to reduce poaching and hunting, which enhances conservation efforts. So our research adopts a holistic approach where each element feeds into the other. So it's fairly organic. It develops throughout the process. I think we're on our 4th iteration now of the project. And it's brilliant because there are things that we would never have realized along the way that are now becoming evidently clear that we have to kind of embed into everything that we do. So the surveillance system, and I'll unpack the surveillance system, the qualitative data collection and community engagement in a little bit more detail next. But ultimately, this is a co-developed community-centered surveillance system. The qualitative data collection occurs before, during, and after the deployment of our study phases. So this is in-depth interviews and focus group discussions to understand species most commonly hunted, the rationales for poaching in areas, also as hunting and scavenging, and awareness of disease transmission dynamics. So it's looking at the local awareness of diseases and how this affects behaviors and risk-taking. Community engagement, so we are engaged. I've been very, very fortunate to have been really welcomed into reformed and active hunter and poacher groups. Oh, do you mind muting yourself, whoever's just taken off? Thank you. So I've been really, really fortunate to have been given unprecedented access. This is a very cagey, very sensitive subject, and in a lot of countries that I have been working in, it's illegal as well. So I've done a lot with research assistants and organizations in the community to really build trust, to be able to gain access into understanding these kind of rationales for poaching. And this has been set up through a number of groups. One is an extensive network in Uganda, for instance, called the Reformed Poacher Network, where we're able to go in and really tap into their expertise and talk to them about coming into the program. And as I say, public engagement, this is something that we're moving into a little bit later on, which is challenging the harmful ideas with regards to why people consume wild meat and the motivations for that. Often it's because these individuals have no other choice, but there are cultural and social dimensions to these rationales that need to be better understood in the wider picture rather than just cutting off access. And if we cut off access to wild meat, ultimately you'll drive the sale underground and make it much harder to predict its movement. And capacity building. Most important is to increase veterinary public health and social science capacity at a local level. This is through the training of poachers to become veterinary health technicians. This is through a wonderful program with organizations such as Conservation Through Public Health, but to also equip local research assistants with social science skills to assist with the collection of interviews and focus group discussions. So I am rattling through, and do please stop me if I'm going over time, but the surveillance system, as I say, harnesses local knowledge. How does it do that? Okay. Well, we work with reformed and active poachers, hunters, and scavengers to track animal behavior changes, animal population number fluctuations, report carcass locations. So once they are located, and this is via mobile phones, local veterinary health technicians will respond, quarantine the area, take samples back to local labs. This is usually, if we're looking at Bwindi as an example in southern Uganda, this will then go to Masaka, or there is a small lab in Bwindi to analyze the presence of that disease. So it's an accelerated process. Now, the reason we look at animal behavior change and animal population number fluctuations is because these are clear indicators of the presence of an emerging infectious disease. Let's take in the Great Apes Ebola virus, for instance. We have seen cases of Ebola virus in great apes, such as mountain gorillas, up to a year before we see cases in humans. So it's about jumping onto this in the first instance and kind of dealing with it there and then. But this also allows us to track wild meat movement. So these individuals are essentially very much aware of the pathways in which these products are being transported between neighbouring communities, but also in neighbouring countries. And I'll show you the findings of our first study of that as well. And to also support local conservation research. So this information isn't only important for the tracking of emerging infectious diseases, but it also helps us collect vital information about population numbers, behaviours, and kind of factors that influence their decline in the wild. So the quality of data collection, I'm going to have to rapidly go through this. The quality of data collection element of it is we have already conducted in-depth interviews and focus group discussions, as well as ethnographic methods to understand the social drivers of spillover, rationales for wild meat or bushmeat hunting, and the awareness of disease transmission. And our community engagement, as I've mentioned, is the sole purpose of this is to increase awareness of disease dynamics and modify behaviours surrounding human-wildlife conflict. So our preliminary results, so we worked last year and the year before with Simone and the US CDC, as well as Conservation Through Public Health, to look at the effects of COVID-19 on hunter-scavenger behaviours, especially in Bwindi, impenetrable forest in southern Uganda. Now, unfortunately, as a result of COVID-19 and the loss of ecotourism, there was a quite significant spike in hunting and poaching in the area, and this was due to a lack of food to protect crops from invasive species, a lack of money, and peer pressure from other community members. Now, there's a collective awareness that this behaviour is illegal, but community members felt like they had no alternative to supplement their diets or incomes during this period. So what we did through our topic guides, so our interviewing, is to really establish what species were most commonly hunted, the rationales as to why, and whether or not these individuals were aware of the risks of hunting these species. So as you can see here, this is some top level data. So bush pigs, duikers, which are small deer, monkeys, baboons, etc. If it has a little star next to it, these are known EBOV host species or reservoirs. And the 2 stars essentially is those data suggest they are potential Ebola virus hosts. So beyond that, so we conducted 125 interviews, as I say, with active and reformed poachers. And beyond that, we are just this week actually launching a new study in Guinea, which looks at African fruit bats and then their consumption and risk of Marburg exposure and spillover. So outputs from that, we put a report together for CDC USA and for UNICEF, which looked at hunting behaviours and spillover risk. And there's a paper which will be coming out fairly soon. I just need to actually finish it, which is called From Forest to Forks, Understanding Hunter-Scavenger Behaviours as a Predictor for Potential Ebola Virus Spillover Events in Bwindi, Impenetrable Forest, Uganda. I'm aware that I am slightly over time. However, the long-term objectives, as I'll talk, is we really want to deploy this surveillance system in other country contexts. The process itself, or the actual project itself, is quite novel, but it's quite adaptable and easy. So the idea is that once it's refined, is that we can then give it to other organizations, to universities, whoever it may be, as a blueprint, which then can be adapted. And this is really about this co-ownership, co-development, tapping into local expertise, but empowering these systems of knowledge and ultimately providing alternative livelihoods that benefit not only those individuals, but also the species we coexist with, and mitigates the threat of pathogen spillover at the same time. So this is I'm very open to suggestion. I'm very open to people coming and approaching us and saying, we really want to take this because we're now applying it in the conservation space specifically, but also in public health. But to do that, I want to tailor it to other pathogens. At the moment, I'm looking specifically at Ebola and Marburg, but I have a PhD student working on Rift Valley fever, where we could apply a very similar thing with farmers, where we're tapping into their systems of knowledge and really using it to create these sustainable surveillance systems where we're not waiting or relying on those individuals to report to a vet, to a doctor. We are ultimately increasing that or speeding up that time in which we can kind of locate the source of an outbreak. So we also want to increase veterinary public health and social science capacity, increase early career researcher and research student involvement to develop and refine the project, and increase community and public awareness with regards to wild meat consumption and rationales for it. And then there's the academic side of things, where we want to contribute to anthropological knowledge regarding social drivers of spillover, systems of knowledge, and multi-species ethnography, and to really catapult the need to understand the social dynamics of spillover as well as the biological dynamics of spillover. And that is me done.
Thank you very much for your presentation. And we did start late, so you didn't go over time at all. It was very interesting. Thank you so much. There's already a question in the chat, but we might move now to the next presentation and then bundle all of the questions together. Yeah, I think we can do that, and I will have plenty of time for all of the questions, and that will also leave you some time to think about it. So now we have Bronwyn, Nichol, and Hazael Biwott, from IFRC, who are going to present on anthrax in Kenya. So Bronwyn, you are the Epidemic Preparedness and Response Focal Point for IFRC on the African continent. And you support 49 national societies in the African regions to be better prepared for early action against epidemic risks. And Hazael Biwott from Kenya is from the Kenya Red Cross and will be presenting with you. He is the community-based surveillance officer for the epidemic and pandemic preparedness programming in Kenya. And he supports all of that work, as I just said, in Kenya. So over to you for your presentation, and we will be taking the questions afterwards. Thanks. We can see your screen, but we can't hear you.
Unmuting, of course. Technology is never my friend. So we're very lucky actually to have Hazael with us today, who will do mostly the bulk of this presentation, as he's been the one doing a lot of the work in terms of what Kenya Red Cross has been doing. And we're really going to look at an example of what they've done with regards to anthrax. And what does it mean when we're talking about One Health? What does it actually look like at community level to be doing this type of programming? So just a quick overview in terms of what the Red Cross Red Crescent approach is to One Health. In general, IFRC really does look towards promoting community action to strengthen resilience, reduce risks, and better prepare for disasters, and these include epidemics. So since 2017, we've been working to pilot an approach to One Health, and we've been doing this across both Africa as well as in Asia Pacific, and we've been looking primarily. Well, the countries that have been implementing this program are Kenya, Uganda, DRC, Cameroon, Sierra Leone, Guinea, Mali, although Mali has now phased out, and then as well as Indonesia in the Asia region as well. So this has taken quite a lot of the learnings, or maybe not learnings, that came out of the West Africa Ebola outbreak, and really trying to think through what will it take to make communities better prepared for epidemic risks, as well as the national societies themselves. How can they be better prepared for early response? So one of the things that came out of this was the need to really look at things from a One Health angle and not just focus on the human health side. And this has been a bit of a shift within Red Cross Red Crescent. We're typically known for how the support that we give during epidemic outbreaks, but really trying to shift and build these relationships as well with both animal health and environmental health actors, which has been a bit of a slow process, but as you'll see from Kenya, they've done a wonderful job in really building those relationships and trying to also build the connections between the different actors at subnational levels as well. So within Kenya, there's a number of program sites. Kenya Red Cross is targeting over 2,300 villages within 4 high-risk counties. So these are West Pokot, Narok, Tharaka Nithi, and Bomet. And so these were chosen in consultation with Ministry of Health, Ministry of Agriculture, and other partners such as WHO at the country level. And what was really looked at in addition to human health risks was also things like the movement of livestock and wildlife across both national borders and international borders, and looking specifically at game reserves. Also looking at what have been historical hotspots for both human and zoonotic diseases as well. And then what is the movement of people across some of these borders? So for example, the site in Pokot was chosen based on the risk of importation from Marburg from actually in 2017, 2016. That happened in Uganda. When we're down looking at Narok and Bomet, these are sites that are around the Masai Mara Game Reserve. So there's a lot of interaction between people and wildlife as well as livestock, both from the Masai that live traditionally within the park and those that surround the park. It's also a traditional hotspot for cholera. And then Tarakaniti is also around a game reserve. So really looking at a lot of those interactions that happen in day-to-day life in Kenya between humans and animals. So what Kenya Red Cross has really focused on in terms of the different sources of information that they've used to support an IOA approach to One Health. So there's 4 main things that really feed into their day-to-day activities. And these are community-based surveillance, community feedback, school health clubs, and One Health committees. So when we talk about community feedback, it's something that comes up quite often when in Red Cross, really making sure we're listening to communities, knowing what the rumors are, what beliefs and misconceptions are around health and health issues, and how we can address them and how they feed into the behaviors that typically tend to happen in outbreaks or in preparedness. Making sure that we're also listening to community recommendations, making sure we know from communities what they think has worked well, what hasn't worked well, what they would like to see done better, and then really using the networks of knowledge that already exist within communities. So whether this be traditional healers, religious leaders, if it's farmers groups, if it's Boda associations, really making sure that all of those people are engaged and figuring out how we can use their knowledge of their communities to get messages across, but then also make sure these things link into things like the community-based surveillance system. School health clubs is a big part of Kenya Red Cross's health programming, making sure as well that the school health clubs are also linked into CBS systems. School health clubs have been working to develop school health plans, looking at how they can better improve things like latrine coverage, both for schools as well as in the communities from which students come from. And the One Health committees has been something that Kenya Red Cross has done particularly well. When we're in a country like Kenya, which is decentralized, so this means that all of the decisions and all of the action that happens for any type of outbreak comes from the subnational level. We often see a lot of the investments go in at a national level and it doesn't always trickle down. So really working with these One Health committees at county and sub-county level around multi-hazard contingency planning for both human and animal health risks, looking towards resource mobilization to see how these things can remain sustainable, putting policies and guidelines in place, and then also working to strengthen these committees to be able to support early investigation. And that also then links into the community-based surveillance system, really making sure that this takes into account not just human health risks, but also animal health risks, making sure it links into existing different surveillance systems. So in Kenya, for example, there is the human health system, there's the wildlife system, and then there's also one for livestock. So it's different systems, and how do we make sure the community-based surveillance data feeds into where it needs to go, and making sure there's an appropriate response that's able to come out of those alerts that are put into the system. So I'm going to pass over to Hazael, who's going to talk a bit more in detail about some of the different aspects. So Hazael, over to you.
Thank you, Bowmer. Thank you for the introduction part of it. Maybe I'll just spend some few minutes and then I will hand this presentation. So as Bronwyn said, the One Health committees, their main role, of course, they have terms of reference that guides the operations, but our main role is just to build capacities within the counties and sub-counties, and even to the community level of having these One Health committees, even coordination at the community level, but just to build their capacities. And as well, of course, also planning for resources and response between partners. And like we have the government and other partners that are coming in, we need to plan them and ensure that they are working harmoniously with other people. And then also facilitate monitoring of One Health implemented activities in the counties so that we don't have duplication in areas that we are supporting. If there are new partners that are coming in, then we need to have them coordinated well. So these structures also, yes, we have the others being done in the community, but again, we need to have coordination even up to the community level, even having those networks in communities where the animal health assistants, the public health officers in those areas can coordinate and they can do the activities well. Next slide. So one of the sources of data is community-based surveillance, and where we get a lot of data so that now we can analyze this data and use this data to support response and even source for other response. So in Kenya, we have a pool of volunteers. We have a total of 890 community volunteers, and these volunteers have different capacities. They've been trained on epidemic control, again, to support health promotion in communities, and even now specifically to also support community-based surveillance. And this now is just to teach them on community case definition so that they can identify cases in communities and report to respective public health authorities. And again, when we detect these cases early, then there is early action for these cases with respective public health authorities. So over the years, in 2022, as you can see from the graphs, the community volunteers have managed to really detect cases in communities and escalate to the public authorities. And in the case of Anthrax, in 2022, they managed to detect 15 alerts. But again, looking at the other zoonotic diseases like rabies, you can see it's 105. At least those cases were detected in communities and escalated to the public health authorities for response. And this now even informs even issues of feedback in communities, where communities meet and we share this data with communities so that communities can prioritize what needs to be done, looking at the cost-benefit analysis of these diseases in communities, like for the case of Anthrax. Instead of you losing a cow, what 40,000, so what are the things we can do? So we discuss with communities and ask them to really focus on the prevention part of it. So you have communities coming in to support issues of response and even co-funding activities to respond to maybe ring vaccination against Anthrax, and having communities also to dispose the carcass so that the communities cannot feed on these carcass. So the community health volunteers in communities are local. They support us to detect these communities, escalate to the public health authorities. That is now where the One Health Committee finds data to interrogate and even look for, if they don't have vaccines, then they look for other partners to come in and support, and even have the communities themselves respond to these alerts. So next. Another source of information is now the community feedback. On monthly basis or on weekly basis, the community health volunteers, together with their representative, meet, discuss, and even get to understand the rumors, suggestions from the communities, what are the concerns from the communities. If there was an outbreak of, let's say, if there was a case of Anthrax that was detected and has not been responded, then this is the session now to meet and discuss that. In the last month, we detected 2 cases of Anthrax. What is the response status? And then now you find the communities coming in and agitating for demand. They demand for the service from the government, and that is where now the demand is cleared by the communities. Then now the public health authorities can respond. If that is not in place, then we have the other private sector that comes in to support the response bit of it. And that is where now the communities co-fund the activities, and that is part of sustainability, having the communities taking up and holding up the responsibilities in the communities. And then again, it strengthens the feedback, the surveillance and referrals with communities, having these feedback sessions with the communities. Then now that linkage between the facilities and the communities is really strengthened to enable faster disease alert responses. And then again, as part of you remember Bronwyn said that the One Health Committee develops multi-hazard contingency plans. But again, we encourage communities to also create their own community action plans that now prioritizes the diseases, identifies the risk in the communities, and even the community themselves draws or identifies the possible solutions to these diseases. Though these community action plans are prepared in the communities, but again, looking at the One Health approach, having an animal health assistant in place, having a public health officer in place so that they can discuss. In our area, we detected rabies cases. For the last 2 months, we have 10 rabies cases, we have 10 Anthrax cases. Then what can we do? then we need to do a ring vaccination sort of, who will support us, maybe a private animal health assistant. Well, then what can we do? We need to contribute like 20 bob or 100 shillings. Then that is again a cost benefit analysis. Communities discuss and say, if we don't vaccinate our animals, we end up losing our source of livelihoods, of which it is this much amount of money. So next. Again, the school health clubs, we are looking at the school health clubs as agents of change. The learners in schools, and this is a youth-led process. We want to have the next generation that understands issues of epidemic preparedness in communities and even can support to detect diseases in communities. So once the schools, through the school health clubs and the patrons are informed on the community case definitions, then these learners in school can even go home. If they identify a case, then they bring back the feedback to their patron. The patron now escalates the same to the public health authorities that yes, as a learner has reported to me that there was an anthrax case in home, there was a dead cow in home, and then now the next level of actions are taken to action, where the public health authorities are informed of what needs to be done, and the communities, and now that enhance the response. So in total, we have 200 school health clubs, but again, we need to expand more so that we have more learners being taught, and they can really support issues of awareness creation in communities. So again, the One Health approach applies in schools where the learners are taught on the One Health approach, the zoonotic diseases that affects them in communities, and this is contextualized so that in your school, what are the common zoonotic diseases? If it is anthrax, then the learners are taught on the case definitions. If you see an animal that has died suddenly, then come and report to the teacher. And then they also support to enhance awareness creation in homes that we need to bury or dispose a carcass of such. So they are advocates, and we're also looking at the next generation of One Health experts in communities. Next. So this also bringing it all together, community-led response for early action against anthrax in Kenya. And this is where the communities take up their role, whereby from the alerts that are detected in communities lead the response, whereby it's up to them to honor the response, identify the risk, identify the cost-benefit analysis. The cost-benefit analysis in such is if I don't vaccinate my animals, what are the risks that come in place? I will lose my livelihood. If it is case of, let's say, rabies. In Kenya, there is shortage of rabies vaccines, and if you get it, it's expensive. So you end up spending a lot of money treating that disease, unlike vaccinating a dog, which can cost you less money. So that brings the cost-benefit analysis and understanding the communities. So in Kenya, for the anthrax case, we had an anthrax case back in 2021 where the community volunteers, and this is in Masai Mara Natural Reserve, a village that borders the Natural Reserve, was identified. There was a young man and two students that I didn't meet from a dead cow and became sick. And again, this is the issue of culture in the community. This is a community that they really handle the animals. And even though they were familiar with anthrax, many people were skeptical of the risks because they usually have some methods of preparing this meat before they eat, using some herbal medicine. But again, that day that they didn't use the herbal medicine, and that is why it backfired to them. And the goats and sheep were affected, and were also showing signs of illness in the communities. And that is where now a case was reported to the public health authorities. So next. So the response system, as I had informed you, is that the SMS was sent. We have a surveillance system that we've set up, and having the volunteers that they can report cases from communities using a phone. It's very simple, and it is very easy for the volunteers to report. So they send us an SMS. This message is received by the respective public health officer or an animal health assistant or the veterinary officer in place. Then again, before a response is initiated at the government level, then this volunteer mobilizes his community. They do a dialogue that, yes, we have a case here, what can we do? Before the government comes and responds with ring vaccination and the others. But these volunteers also mobilizes their own community to do a dialogue and again ensure that local actions are being done. So wide health information and awareness raising activities were done. Then again, radio broadcast activities were done, household visits, group information sessions, and this is done at the communities. And within a month, then the communities mobilized themselves to vaccinate over 10,600 cattle, and 14,000 sheep were vaccinated in the area. Then again, communities now recognize the risk exposed by anthrax and put in place systems to plan. And this is where now the advocacy bit of it comes in, whereby even from that village, then the communities adjacent to the communities managed to even co-fund the activities and even facilitate the vaccination of these diseases against anthrax in communities. That is part of advocacy, and even in communities, sustainability happens in communities, whereby communities co-fund activities. They even plan for calendar of events of ensuring that in the month of maybe June or July, we are experiencing cases of anthrax in communities. What can we do? Then communities comes in, they co-fund activities, they co-create work plans, and even if there are no vaccines within the government system, they engage the private veterinary officers to come and vaccinate the animals. And that is part of sustainability in communities. Next. Yes. So the recommendations for this and one else is of engaging existing community actors. We need to identify the community actors in communities and engage them. This is, of course, focusing on the One Health spectrum of having all the actors in human health and animal health to understand the priorities and needs, even the communities to understand these priorities and needs in the communities, identifying the risks and prioritizing these risks in the communities. The next generation, that is why we need to engage youths, because see that the next generation, they really need to understand, and they are advocates in communities. And then advocate for, of course, human resource in animal disease resources, that we need to have more human resource to support issues of response in communities. And then again, we need to also have more health signals into existing CBS systems so that we can detect more diseases. The first presenter was focused on epizoonotics. Then we really need to have more of health signals into our CBS system so that we can detect early zoonotic diseases early in communities, and even communities to understand these community case definitions so that they can detect early cases and support to detect and even for early action. Again, another recommendation is also vaccine availability. We need to also map vaccine availability and advocacy at county level. There are a lot of partners that comes in to support vaccination in counties. But again, with the data, we can support the counties or the government can support them to even channel their vaccination well using the data that is available. That in the last 2 years, we had anthrax cases. These were the locations. Then if you are coming in to support the vaccination, then prioritize these areas. And again, these are maybe issues of even understanding the diseases in our communities. Then if there is any support to support vaccination, then at least you know the profile of diseases in your community using available data so that you can even easily source for vaccines that are relevant to your area and that the community needs. Of course, harnessing community information and having the community tell you what they really want in their communities. So that is it. And thank you from Kenya Red Cross. For more information, we can share with you a link so that you can see a document that we did. So thank you. Back to you, Bronwyn.
Thank you very much. Oh, sorry.
No, back to you.
Okay, thank you so much to both of you. This was a very interesting presentation too, and practical example of One Health application on the ground. All of those presentations have elicited many questions, and that's very exciting. Bronwyn, would you mind stop sharing your screen, please? Thanks. Great. So we'll go to where did all the questions? Oh, there they go. So we had many questions for Alex and many questions also for both Bronwyn and Hazael. Maybe we'll start with the first. Sorry, I didn't go through all of the questions, but the first question was from Nichol. And if any of you want to speak to your questions rather than me reading them from the comments, please do raise your hand and I'll give you the floor. Alex, you might have had time to read that question. Was as part of community engagement or any part of the work, have you gone through the process of behavior prioritization, root cause analysis, and community action planning with the communities?
Absolutely, yeah. Thank you for the question. I think I was conscious of time and not going into kind of like the complexities of community engagement, and especially when we're looking at wild meat collection and consumption, it's really complex because most of the countries we operate in, it's completely illegal. So I do explain it more in the paper, and as soon as I get it finished, I will circulate it. But ultimately, you have to separate communities in the sense of we have a community of active reformed poachers, hunters, scavengers. They act within a community that requires its own strategy, where we understand behavior prioritization and the root causes of their activities, and then have a separate community engagement strategy for the communities existing around all of these activities. So I won't spend too much time going through it, but ultimately, yes, all of that is there. It is broken down in the paper that I'm kind of writing now, and as soon as I've done it, I will kind of circulate it. It will be open access as well, so anyone can read it.
Fantastic. Thank you so much. And I think someone else asked for you to share in the comments here the link to the post to the title of the Forest to Fork report, if you could post that. So there was, I'm just going to ask those other two questions that came from Anais and Hillary, and actually I had a similar question as Hillary, so I'll just put my question in. So Anais was asking if what kind of collaboration you had for, especially for Rift Valley fever. Did you connect with OIE, WAHI, I think now, WAHO, and FAO? And then Hillary was asking about how had you been able to identify, when you identified Ebola in gorillas, how did you link that to human spillovers? So how did you have a chain of transmission that you identified?
Absolutely. So first question with Rift Valley fever. At the moment, we're doing this independently. We are looking at launching this with MRC Uganda and with UVRI. The reason we haven't gone beyond that is because sometimes there's a lack of acknowledgement with regards to the healthcare systems that are set up with regards to the management of Rift Valley fever, and that is the presence of alternative providers of veterinary care in very rural and remote areas. Now, in the ideal world, we have veterinary capacity, we have technician capacity, but ultimately farmers, when they are initially responding to the early signs of Rift Valley fever, are self-managing them. They're using boda drivers, they're using local chemists, they're using traditional healers, etc., etc. That has raised concerns as to, well, what they shouldn't be doing this. They should be looking out for veterinarians, etc. So there's been a little bit of conflict. So what we're trying to do is operate independently, do health system and kind of health seeking behavior mapping analysis first to say this is who, or these are the individuals that communities are reliant upon, whether this be instrumental or detrimental to the kind of response to Rift Valley fever is yet to be determined. But ultimately, once we have those findings, it will then be circulated and we'll be having larger conversations with those organizations. But in the first instance, there's quite a lot of distrust with foreign agencies, government, etc., especially in the communities we're working with. So we are listening to the community first and then presenting the health systems maps beyond that afterwards. With regards to the gorilla question, so this wasn't a study that was conducted by us. This was kind of in our kind of foundation setting. So the largest study that's been done was actually came out of the Bronx Zoo. So they have a research unit, and I can share the paper, I can circulate it afterwards. Unfortunately, they ran out of funding, which is a real shame, but they did some amazing work in 4 different countries and looking at the emergence of epizootics as potential precursors to zoonosis. In that, they looked at gorillas as well as a number of other primate species and found that prior to 4 major zoonotic outbreaks of Ebola, they found Ebola virus circulating in certain primate species a year or even beyond that when samples were taken, etc., etc. So the idea kind of for this spurned from their research and others to look at, well, is there a link there? And this is something that we're going to be exploring more tangibly as we go forwards. Now, as I said, I'm a social dynamic specialist. I'm not a biologist. I'm not an epidemiologist. So the idea is that, well, if anyone is on the call and is interested, please let me know. But ultimately, as this program develops, we'll be bringing in more and more expertise to look at how we bridge these gaps in our knowledge, and ultimately kind of develop upon the findings of papers such as this. And with regards to the Forest to Fork report, yes, I don't exactly know where it is at the moment, but I can circulate it around after this.
Thanks, Alex. Thank you very much. So let's, I'm just going to move to the other presenters to let them also answer some questions. I had a question that hopefully would cover both of you. So I'll just give it here, and then so you have time to think about it. You mentioned, Alex, and also obviously Bronwyn and Hazael, how with a practical example, but how do you foresee that you could more generalize this more? Alex, you mentioned a tool, but would it come like kind of a toolkit of how do you approach the poachers, etc., and how do you incentivize them to actually report? Because as you were saying, it's illegal in many countries, and same thing for Bronwyn and Hazael. The example that you gave is great because you have a vaccine against anthrax, but how do you do it for other, how would you imagine doing this for other diseases where you don't really have a preventive measure for the animals, for the livestock, and how do you get, farmers to report on outbreaks in their poultry of avian influenza when the response strategy is going to be to call all of the poultry, and how do you incentivize them that way? So I'll just let you think about this, and we'll go to the questions for Bronwyn and Hazael. So there was one question. I'll just give you all of the questions. You can write them down and then answer them. So Simone was asking how the One Health committees been in other countries, and she apologizes if you already said it. I don't think you did, but would be interested to know. We did have some great examples from IFRC in one of our field exchange, but not on One Health specifically. Then yes, and I had the same question as Grace, that if you could just specify what unusual human and unusual animal was, that would be helpful. Also, how do you communicate with the school clubs on One Health? And do you have kind of a toolkit around this? And then a question from Dear Gracias. How do you ensure that there is a link between the national preparedness response plans and the community action plans for disease preparedness? So for now, we're going to stick to those. I think it's already a lot, but just to make sure that we can cover all of those questions. Over to you.
Thanks. I'll start off and then I'll throw over to Hazael for the things I can't answer. But in terms of One Health committees in the other countries where we have this program, it varies. So oftentimes they do exist at national level. We've been working, Sierra Leone's looking at really pulling this down to chiefdom level in their next round. In Guinea, they do exist at the prefecture and sous-prefecture level, and they're quite functional, at least in the zones where we've been working. In DRC, not so much. It's still something we're working towards. Cameroon, not really either. But in Uganda, yes, it's working to varying degrees at the subnational level as well. And even within Kenya, I mean, in theory, they exist in every county, but their level of functionality, even within the different counties where we're working, it shifts based on, as with everything, the people and the amount of buy-in that's happening. With regards to unusual person, yes, it's something that shows up in our coding, which we really should change. But it's just the signal to pick up there's been an unusual event, either in a human or in an animal. So it's just something weird that has happened, and it just gives the coded SMS that a volunteer can send into the surveillance system. So we don't know what it is. Oftentimes, sometimes it's actually nothing. Other times it'll come back from ministry after an investigation. We've had some of these come back, particularly with regards to zoonotics. It's like peste de petit ruminant, which we don't have fully in the system, but that's often what comes back. And sometimes brucellosis comes back in that sense as well. With regard to school health clubs, I will pass this over to Hazael because he's worked quite extensively on this as well, but they have quite a number of good tools, and it's quite tailored to working with school kids as well as with the teachers themselves who serve as resources. So Hazael, over to you.
Thank you, Bronwyn. For the school health clubs, we do have toolkits. The ECV toolkits are epidemic control for volunteers toolkits, and for learners to get it right, of course, you have to have the patrons being trained, and the patrons will now be taught the approach of One Health. Then now, if the patrons get to understand this concept, then again it will be easy for them to pass it to the learners. But again, periodically, then we have public health officers and animal health assistants visiting schools to mentor these health clubs. And that is where now they really get to understand the approach of One Health in communities. But again, looking at using the real or the contextual diseases in communities. If the school is the main risk in communities is rabies or anthrax, then that will be a disease of choice to drive the agenda of One Health approach in communities, in schools. For the community health action plans, like relating it to the national action plans, then again, ideally, for you to develop a multi-health contingency plan, you need to start from bottom, and this is where you visit communities, understand what communities say, the risks in communities, what are their priorities, what are they planning to do to avert the disease in communities. And that is now where you move. But again, if you have the national action plans or the even counties or county action plans, then again you disseminate the communities. That the committees are down, and these are the action plans that are prioritized. What are your roles as community? These are your roles as a community. Then you need to do this as a community. Then our community can prioritize and do those action plans. And that is where now the connection comes in. After the action plans developed by the county or sub-county, then come and disseminate to the communities. That we sat down. These are the risks in your communities. You need to. These are your roles as the community. These are the roles as the government or the partners. These are their roles. For you, the community, these are your roles. You need to do this and this and this, so that you can strengthen or avert the risk in communities. But again, in some other context, we develop the action plans with communities. Then during the quarterly One Health meetings with the county or sub-county, then now we disseminate these action plans with the county and these sub-county action plans that the communities are prioritizing this and this. Then during the review of multi-health contingency plans, then now they add in what the community is prioritizing so that they can strengthen the action plans for response and preparedness at national and the community level. Yeah, so that is it. Thank you.
Thanks very much. So we have 3 minutes left. So 1.5 minutes per organization to summarize how you can generalize your approach. And I'll start speaking. Over to you, Alec.
Okay, I'm going to be quick. The takeaways. First and foremost, I think we're all very fatigued of toolkits, so we need to think of other ways in which we can deliver these blueprints for these projects, right? The key thing with our system is it's context specific, so it cannot be a copy and paste model that can be applied anywhere and everywhere. But the learnings, the approach, the methods, they can be. So I think that's the number one thing. It's about network building. It's about what methods have worked really well for us. We've innovated methods of interview techniques to really draw more out, giving kind of situational questions where we're kind of using free listing or rank ordering to map out kind of species that are hunted, rationales, etc., etc. But the most important thing is to listen and not go by what we have done for a while. And then this comes down to even reimbursement. And you talked about buy-in, right? One of the things we looked at buy-in is reimbursement for time, for interviews, etc. Instead of saying, oh, well, usually we give $2 or a bar of soap or a pair of shoes. Have you actually asked the communities what those individuals, what they want? So this is one of the first thing we did in our community meetings was, what would you like in return for sitting down? And they said, well, can we club together and get goats, or can we club together and get this? So it immediately shows you're listening to what these individuals are saying, and then providing pathways. So alternative livelihoods provisions. This is veterinary healthcare technician training. This is employment under data collection, etc., etc. So ultimately, the blueprint will take a form of maybe a report or something, which I'm trying to stay away from a toolkit, but it will be available hopefully by the end of this year.
Thanks. Thank you very much. Over to you, Bronwyn and Hazael.
Yeah, I think it echoes on the same thing, that we can't just do what we've done in one country and pull that somewhere else. But really what some of the health tools that we have within IFRC, which really focus on having communities feed into, as Hazael was saying, into their mapping, and really trying to expand this as well to include more, not just human health risks when we do this community mapping, but also looking more on the animal health side, and as well as on climate on that side as well, to really pull all these different risks together to come up with a more unified plan. And that's something that there's work ongoing in terms of how we can make these tools not just so siloed, because we tend to have them for the different areas, but how can we bring them together so that national societies or communities just have to do something once and they don't have to do it multiple different times depending on what the donor wants. And so how can we make that easier for them? And then the other thing is really around adaptability, particularly when we're talking with CBS. On the human health side, it's a lot easier. Most countries use DHIS2. It's easy for us to figure out how we can feed into that with CBS. Animal health, it's all over the map in different countries in terms of what systems people use. And that makes it that much harder on the animal health side, and having something that works quite easily when you're jumping from context to context. And that's still a challenge we're grappling with on this side.
Amazing. And we're on the dot, and I don't know how you say it in English anymore. Sorry, it's Friday. Thank you so much for those presentations to the three of you. It was really great. I think everyone really enjoyed this session. I think this also calls for a field epi, field exchange, IOA field exchange and volume. Maybe we need to think about that. I wish you all a great weekend and see you in 2 weeks. Thank you so much. Bye.
Have a great weekend. Thank you.
Thank you.
Bye.